Hello, and thank you for giving me the opportunity to present today on our PRAMS Zika Postpartum Emergency Response Project, or PRAM-ZIPPER, and we're going to look at how we can prevent sexual transmission of Zika virus during pregnancy. And so today, what I would like to talk about are what we've learned regarding predictors of condom use during pregnancy, as well as how effective counseling messages are for preventing Zika virus during pregnancy. So Zika virus infection can cause microcephaly, brain abnormalities, and other severe birth defects in offspring. And pregnant women can get Zika virus infection not only from the bite of an infected mosquito, but also from having sex without condoms with an infected male partner. And in Puerto Rico in 2016 and 17, there were more than 4,000 women who were pregnant who were diagnosed with Zika virus infection. And we know that healthcare providers can play an important role in prevention by encouraging women to adopt safer sex behaviors during pregnancy. And so that is what we're going to look at with the PRAMS-ZIPPER data. So recommendations to prevent sexual transmission of Zika during pregnancy were first released in 2016 and then reaffirmed in 2018. The recommendations are that pregnant women and their partners consistently and correctly use condoms when having intercourse during pregnancy, or that they abstain from intercourse fully during pregnancy. The methods for PRAM-ZIPPER were heavily adapted from the Pregnancy Risk Assessment Monitoring System, or PRAMS, which is an ongoing population-based surveillance system between state health departments and CDC that examines self-reported maternal behaviors and experiences before, during, and shortly after pregnancy among women with a live birth. It's located in 47 states, New York City, District of Columbia, and Puerto Rico, typically conducted at 2 to 6 months postpartum via two modes, telephone and mail. For Zipper, we adapted methods from PRAMS and conducted population-based hospital surveys of women who had a live birth between November and December 2017 among women and their partners. And so in the first Zipper study we looked at only women. And because of its success, we were able to expand to men and repeat the survey. Surveys were administered in Zipper 2.0 via electronic tablet or via paper form. The response rates were outstanding at 94% for mothers and 77% for the partners. This article that was published in Emerging Infectious Diseases last year from the first Zipper survey reported high levels of counseling, moderate levels of condom use, and a strong association providing provider counseling and condom use during pregnancy by women. So we wanted to see whether the same relationship existed a year later when we did the study and among women and their male partners. So we examined the prevalence of provider counseling on condom use during pregnancy and the prevalence of condom use during pregnancy. And then secondly, we examined whether condom use during pregnancy differed according to women, whether they received counseling on condom use from the providers to prevent Zika infection. For the measures, the maternal survey, we asked women, during any of your prenatal visits, did a doctor, nurse, or other healthcare worker talk to you about any of the things listed below, including condom use to prevent Zika during pregnancy? Those who were found to be sexually active during pregnancy were then assessed to see how often they used condoms by trimester. For men, we looked at all men who reported a healthcare visit in the past 12 months and asked them, during any of your healthcare visits in the past 12 months, did a doctor, nurse, or other healthcare worker do any of the following things? And one of the options was talk to you about condom use to prevent Zika. Those who were sexually active during pregnancy, like the mothers, were then asked about their condom use during pregnancy. We constructed separate multivariable logistic regression models for both women and men to examine associations between receipt of provider counseling on condom use during pregnancy and the actual condom use reported by the female or male participant during pregnancy. Among women who were included in the analysis and who reported a prenatal care visit, marital status and education level were similar between women and men. Fewer women, though, were aged 35 years or older as compared with men. While nearly all women, 99%, received prenatal care, only about half of men, at 48%, reported attending a healthcare visit in the 12 months before the birth of their infant. For counseling and condom use, 85% of women who attended prenatal care visits and 65% of men who attended a healthcare visit reported receiving counseling from a provider on the importance of condom use during pregnancy to prevent Zika virus infection. Overall, most women, 82%, reported being sexually active during pregnancy. And among these, approximately 1/4 reported condom use consistently during pregnancy. Over half reported not using condoms at all. For men, reported nearly the same, both being sexually active in virtually identical proportions, reporting consistent condom use and reporting any condom use. In multivariable analyses, receipt of provider counseling on condom use was found to be significantly associated with both any condom use and consistent condom use for women. Specifically, counseled women as compared to non-counseled women were 2 times more likely to report any condom use during pregnancy, and nearly 2 times to report consistent condom use. For men, the similar type of finding with both any condom use and consistent condom use, in that men who were counseled about condom use during pregnancy were more likely to report condom use during pregnancy. The strengths of this analysis lie in its large sample size and extremely high participation rate. This also presents a unique examination of sexual activity and condom use during pregnancy. And what is novel are the data were available on both women with a recent live birth and their partners. The data are also subject to limitations in that it's self-reported, the timing of provider counseling was unknown, and that the results may not be generalizable outside of Puerto Rico or outside of a public health emergency like Zika virus infection. So our data suggests 3 main take-home points. First, that most men and women receive counseling and condom use during pregnancy to prevent Zika virus infection. Remember, these percents were at 85% and 65% respectively. However, condom use was less than optimal by both men and women, with fewer than 1/4 of women and their partners reporting consistent condom use, and only half reporting any condom use, despite having possible exposure to Zika virus. And finally, an encouraging sign was that provider counseling on condom use to prevent Zika virus infection was associated with increased condom use during pregnancy among sexually active women and their partners. Several implications emerged from our findings. 3 main ones. First, that healthcare providers can indeed play an important role in preventing Zika virus infection by counseling their patients on condom use. And these findings can be used to target and develop interventions to prevent Zika and other infectious diseases during pregnancy for women and their partners. We need a better understanding of the barriers to condom use during pregnancy, particularly when there's a known risk of infection. And finally, this study illustrates very well how a surveillance system like PRAMS can be adapted to collect data for public health emergencies that are directly linked to pregnancy, specifically interviewing women and their partners at the time of delivery, while intensive and costly, can be implemented rapidly and with a very high response rate during urgent situations like Zika. And lastly, this type of study design may be appropriate for other types of public health emergencies that involve pregnant women and newborns. And finally, I'd love to acknowledge the staff in Puerto Rico at the Division of Maternal, Child, and Adolescent Health at the Puerto Rico Department of Health for their assistance to our division's work in the Division of Reproductive Health to conduct the study and have these important findings. Thank you very much.
Hello, I'm Julie Dombrowski from the University of Washington and Public Health Seattle and King County. The title of my talk is Doxycycline Prophylaxis Use Among Cisgender Men and Transgender Persons Who Have Sex with Men in Seattle. I'm grateful for the opportunity to present this talk on behalf of my co-authors today. Doxycycline prophylaxis may reduce the risk of acquiring bacterial STIs. 2 key randomized studies to date have examined this question. The first was a study of doxycycline pre-exposure prophylaxis, or PrEP, among 30 MSM in Los Angeles. Those randomized to doxy PrEP had a 73% reduction in the odds of syphilis, gonorrhea, or chlamydia compared to contingency management. The second was a study of doxycycline post-exposure prophylaxis taken as a double dose, 200 milligrams, within 24 hours after a sexual exposure. Those randomized to doxy-PEP had a 47% reduction in the combined STI endpoint, which reflected a 73% decrease in the risk of syphilis and a 70% reduction in the risk of chlamydia. These studies are intriguing, but each had some key limitations, and the effectiveness of doxycycline prophylaxis remains uncertain. There are ongoing randomized controlled trials of doxy-PEP in Seattle and San Francisco, as well as in France. Doxycycline is not FDA approved for the purpose of STI prophylaxis, but it can be prescribed in the absence of FDA approval, and anecdotal reports indicate that distribution is occurring in the community and online. The prevalence of the use of doxycycline prophylaxis, however, is not well studied, and we aimed to assess this locally in Seattle. The objective of our study was to assess the prevalence of doxycycline PEP or PrEP use among cisgender men who have sex with men and among transgender persons who have sex with men in King County, Seattle, Washington. To do this, we used the PRIDE survey, which is an annual cross-sectional survey conducted in person yearly at the Seattle Pride Parade. The survey is conducted by public health with the intent of obtaining sentinel surveillance data on key topics such as PrEP use. The survey began in 2009 and allows us to describe trends over time. The collection of Pride data occurs on the day of a Pride event, including the main gay Pride parade and other events such as Trans Pride. A team of trained surveyors conducts recruitment by street intercept and determines whether an individual lives in King County and identifies as a man who has sex with men or a transgender person who has sex with men. The survey is either interviewer-administered or self-administered and collects participant-reported information on demographics, sexual behavior, HIV status, and PrEP use. It is conducted in either English or Spanish, and it is intentionally short, a few pages that take about 10 minutes to administer. Participants receive $15 as well as condoms and information about local sexual health services. In 2019, we added 2 questions about doxycycline prophylaxis with the intent of getting a baseline estimate of use in the community at a time when the intervention was relatively new and the doxy-PEP study had not yet started in Seattle. The questions followed a brief preamble as shown here. Taking the antibiotic doxycycline every day or after having condomless sex may reduce the risk of getting syphilis and chlamydia by about 70%. We asked participants whether they would be willing to take doxycycline prophylaxis and whether they had ever taken it, differentiating post-exposure prophylaxis from daily pre-exposure prophylaxis. This was a simple descriptive analysis. We limited the analysis population to those who had at least one sex partner in the past year and completed key survey questions, including at least one of the 2 doxycycline questions. We stratified participants by HIV status and PrEP use into 3 groups and used a chi-square test to compare the % of use and willingness in each of the 3 groups. The characteristics of the respondents are shown here. The majority, 91%, were cisgender men. The study population had a mean age of 36. 69% were white, 9% were Asian or Pacific Islander, 3% were Black, and 13% identified as Hispanic or Latinx. The majority of participants were HIV negative and not on PrEP, 70%, with 10% who reported being HIV positive. Overall, 9% of the population reported having used doxycycline for STI prophylaxis, either pre or post exposure. And that group was nearly evenly split between those who reported using it as PEP and those who reported using it as PrEP. Stratifying by HIV status and PrEP use, doxycycline prophylaxis use was most common among HIV negative on PrEP, followed by HIV positive and HIV negative not on HIV PrEP. The proportion of respondents who affirmed that they were willing to take doxycycline prophylaxis was substantially larger at 42%. This proportion was higher among HIV positive participants and HIV negative participants on HIV PrEP, with 62 and 60% in those groups, and was lower, 34%, among those not taking PrEP. In summary, we found that among PRIDE survey respondents in 2019, 9% reported using doxycycline for STI prophylaxis, and 42% affirmed their willingness to do so. This differed by HIV and PrEP use status, with the lowest levels of interest among those who were HIV negative and not using HIV PrEP. The level of use that we found, 9%, was comparable to that in MSM in the Melbourne Sexual Health Clinic in 2018, 10%, and to that found among MSM in a London Sexual Health Clinic, the Dean Street Clinic in 2018, which was 8%. The willingness of 42%, however, was lower than interest from other previously published studies, including 53% interest among MSM in Australia from an online survey in 2011, as well as a very high level of interest, 84% among MSM in the US, found in a multi-city survey done on social networking apps. The key limitations of our study is that it was done in a convenience sample and only one geographic area with uncertain representativeness for other populations. In conclusion, some men who have sex with men and trans persons who have sex with men are taking doxycycline prophylaxis in the absence of clinical guidelines. This is a relatively small population at present, and our results provide an estimate from sentinel surveillance that can serve as a baseline for comparison in our area over time. This, along with results from other areas, highlights the need for us as medical and public health professionals to ensure that accurate messages about doxycycline prophylaxis are available and disseminated. This slide, I'd like to acknowledge my co-authors and the many people in the Public Health Seattle-King County HIV STD program who were crucial to the success of the PRIDE survey, perhaps most of all the PRIDE surveyors. Thank you very much.
Hello all, I hope you're doing well and staying safe and healthy. My name is Nick Love. I use pronouns they, them, and I'm the PrEP coordinator for the South and West Side clinics at Howard Brown Health Center in Chicago, Illinois. Today, I'll be presenting on my abstract on PrEP persistence and retention among cisgender women from 2018 to 2019 at Howard Brown Health. Before we get started, I'd be remiss if I did not acknowledge all of the amazing people that helped me with this abstract and presentation. From my co-authors, Maria, Laura, and Michael, to Octavia Taylor, one of our PrEP retention specialists, and of course, all of the Howard Brown Health medical providers that provide competent and gender-affirming care on a daily basis. Finally, I'd also like to thank all the patients who choose Howard Brown Health as their healthcare provider. Thank you all, I really appreciate it. And then here's the overview for the rest of the presentation. We will be going through the background, objectives, methods, notable results, and our conclusion and implications. To provide further background, Howard Brown Health is a federally qualified health center in Chicago, which was founded in 1974. Currently, there's 11 clinical sites throughout the city, stretching from the south side to the far north side, and one clinic on the west side. Beyond that, we're also able to offer outreach services to neighborhoods throughout the city of Chicago. We also are really lucky to have a comprehensive HIV prevention program with 9 team members offering PrEP and PEP navigation, community outreach, and PrEP retention services. In terms of cisgender women in PrEP, cisgender women compose 51% of the United States population, and in 2018 also accounted for 19% of those who are newly diagnosed with HIV. At the same time, only 7% of US PrEP users are cisgender women. At Howard Brown Health, the number of cisgender women engaging in PrEP care was only 5% in 2018, and in 2019, only 4%. With this knowledge, we had a few objectives, including describing the demographics of cisgender women who initiate PrEP at Howard Brown. This is allowing us to better see who we're currently attracting for PrEP care. And then our other objective is to explore how PrEP outcomes differ among those cisgender women who initiated PrEP based on their demographics. And then for this project, we ran a descriptive analysis of cisgender women initiating PrEP at Howard Brown Health between January 1st, 2018 and June 30th, 2019, with follow-ups through December 31st, 2019. What we looked at in particular was patient demographics, including age, race and ethnicity, sexual orientation, and insurance status. We also looked at chief complaint when accessing care and 3 different 6-month PrEP outcomes by demographic characteristics. Those 3 6-month PrEP outcomes were the following: persistence, retention, and total time on PrEP. We define persistence as the portion of days covered being greater or equal to 86%, or in other words, having 6 out of 7 days covered by medication during the first 6 months. And for retention, we define that as having at least 1 HIV test per quarter during the first 6 months on PrEP. And then finally, we looked at total time on PrEP and defined that as the total number of months from the first PrEP prescription to the end of that prescription supply. And then here are the results. So as you can see, the total number of patients was 191. 74% of all cisgender women engaging in PrEP care were between the ages of 18 and 35. We also saw that nearly half, at 47%, identified as Black, with 50% of all people identifying as straight and 67% having some form of insurance, with the majority of those having public insurance at 41%. Finally, the chief complaint for 52% of patients was PrEP. And then on this slide, we can see the persistence and retention compared to cisgender women and their counterparts. We see here the percent of persistence on PrEP was 18, and for retention, we see 29% for cisgender women. This slide also shows cisgender women compared to cisgender men, transgender women, and transgender men. And then the third 6-month PrEP outcome, total time on PrEP, was seen to be in 2018, a mean of 7.5 months and a median of 4 months. And then in 2019, we saw a mean of 5 months and a median of 3 months. And then here we see persistence and retention based on age range, the highest persistence being 33% for those 46 years and older, and the retention being 32% for those that were aged 36 to 45. In terms of race and ethnicity, we saw that those who identified as white had the highest rates of retention at 39%, and the second highest at 27% for persistence. The highest in persistence were those who identified as Asian at 29%, but it is notable to share that those who identified as Asian only made up 4% of those in this study. In terms of sexual orientation, we saw that those who identified as bisexual have the highest persistence at 18%, and those who identified as lesbian or queer had the highest rates of retention at 58%. For insurance status, we see those who had private insurance have the highest persistence and retention at 30% and 36% respectively. And then on our final slide of results, we show the breakdown of chief complaint in relation to persistence and retention. And we see those who had the chief complaint of PrEP have the highest persistence at 23%. And then our conclusions, we saw in the data that cisgender women overall had worse PrEP outcomes than their cisgender male counterparts, along with all of their gender counterparts. We also saw that those who were older, white, bisexual, privately insured, and or self-referred for PrEP were more likely to be persistent. Finally, we also saw that despite the high percentage of Black cisgender women initiating PrEP, Black women do not persist on PrEP at the same time as at the same rates as their white counterparts. And then in terms of implications, we see that cisgender women are often excluded from conversations about HIV prevention and PrEP, and are valuable individuals to engage in programmatic creation and HIV prevention conversations. In direct response to some of this data, Howard Brown Health launched a PrEP retention program on June 1st, 2019, with high priority communities, including Black cisgender women, along with people of trans experience and young men who have sex with men. Finally, Howard Brown Health also more recently hired a consultant to engage Black cisgender women in dialogue to better understand the barriers to care and develop messaging that will resonate more with this part of our community. So that's the end of our presentation. Thank you all for joining me. If you want to talk more about what some implications might be for your given clinic or county health department, feel free to reach out to me at nickl@howardbrown.org. Again, that's nickl@howardbrown.org. Thank you all again, and I hope you have a good rest of your day.
Hello, everyone. The topic that we're going to discuss today is low partner elicitation index and meeting venues for sex partners among people with HIV and recent sexually transmitted infections. My name is Jamie Huang. I'm a data analyst in the HIV epidemiology program in the Bureau of HIV at the New York City Health Department. Studies have shown sexually transmitted infections may promote HIV transmission and increase the risk of HIV acquisition in HIV-negative partners. HIV transmission is more likely to occur when people with HIV is not in care or in care and not virally suppressed. People with HIV who are not in care or virally unsuppressed and have recent STI co-infection represent an important population in need of ongoing partner services. Partner services include a broad array of services, including confidentially notifying sex and needle-sharing partners of their possible exposure to HIV and other STIs, and providing people with HIV and their partners a referral to a range of medical, prevention, and social services. At the New York City Health Department, the Bureau of HIV routinely offers partner services to all new HIV diagnosed persons and people with HIV who are not in care. In addition to STI partner services, the New York City Health Department Bureau of STI conducts partner notification for people with HIV who were co-infected with syphilis, who are newly diagnosed with HIV at New York City Health Department sexual health clinics, as well as for people with HIV who are newly diagnosed with gonorrhea at one of their sexual health clinics. In July 2018, the STI and HIV bureaus began to collaborate on a biweekly match between the HIV and STI surveillance registries to identify people with HIV with newly reported gonorrhea and or chlamydia. This match was conducted to expand the current scope of partner services in order to reach more people with HIV in need of partner services. We prioritize for outreach people with HIV who were not in HIV care, defined as no labs or HIV-related clinical visits in 13 or more months. In care and having an unsuppressed viral load was defined as having a viral load greater than or equal to 200 copies per milliliters at the last reported viral load test. Disease intervention specialists conducted outreach to these prioritized people with HIV co-infected with gonorrhea and or chlamydia to offer partner services, linkage to HIV STI treatment, referral to social services, and ascertain venues where people with HIV met sex partners. In order to assess the effectiveness of the partner services, we then compare partner indices, which is defined as the number of partners elicited divided by the number of persons interviewed. Between people with HIV co-infected with gonorrhea or chlamydia, people who were not in care, and newly HIV diagnosed persons without a recent gonorrhea or chlamydia diagnosis in the same time period from July 2018 to December 2019. From July 2018 to December 2019, we received more than 100,000 newly reported gonorrhea or chlamydia cases from the STI registry. 5% of STI reports matched to record in the HIV registry, totaling 5,362 cases of co-infection with HIV and either gonorrhea or chlamydia. Among those matched cases, 45% were diagnosed with gonorrhea, 41% were diagnosed with chlamydia, and 14% were diagnosed with both. Of the over 5,000 matched cases, 1% were not in care and 10% were unsuppressed. These were assigned for outreach. Of the people with HIV interviewed, 12% linked to HIV care or accept referral services, and 10% received STI treatment due to the outreach. Some people may have received both HIV care and STI treatment. The majority of not in care and unsuppressed people with HIV with recent gonorrhea or chlamydia were men aged 30 to 49 years. The majority of cases occur among non-Hispanic Black individuals, Hispanic individuals, and those classified as men who have sex with men as the probable HIV transmission risk. This is defined as a combination of self-report and data from HIV surveillance registry. Overall, 93% of people with HIV with recent gonorrhea or chlamydia declined to name any partners, and only 35 partners were elicited during the study period. The partner index for not in care co-infected people with HIV was 0.09 and 0.07 for the unsuppressed co-infected people with HIV, compared to 0.04 for not in care people with HIV and 0.33 for newly HIV diagnosed person without gonorrhea or chlamydia. 176 people, or 40% of the 440 persons who did not name any partner, offer a reason for not doing so. Among those who offer any reasons for not naming partners, 31% said their partner were anonymous. 31% already self-notified the partners of their HIV and STI diagnosis. 27% reported their partners were already known to be HIV positive, and 5% each said partners routinely tested for HIV and STI or were taking PrEP. Most co-infected people with HIV reported using dating app to meet partners, followed by bars, clubs, or dancing halls. In conclusion, eliciting partners was less successful among those who were already diagnosed, even in the presence of a new STI co-infection. Additional or novel modes of outreach may be necessary to identify partners among this group of individuals. Effective partner services and the critical action of eliciting partners who may benefit from additional intervention should continue to be conducted at the time of HIV diagnosis. Of people with HIV interviewed, 12% linked to HIV care or accepted referral services, and 10% received STI treatment due to the outreach. Despite the low partner indices, People with HIV with recent STI constitute an important group for partner services in linkage to HIV and STI treatment. Thank you, and this is my contact information.
Hi, my name is Rachel Welch. I'm a pediatric resident at Rainbow Babies and Children's Hospital in Cleveland, Ohio. And today I'll be speaking on behalf of Dr. Koumans, who is actively engaged in the COVID-19 response. I'm pleased to present our initial findings on our synthesis project examining the differences of adolescent condom use trends by global region. As this audience knows, STIs are a persistent global problem, and in places such as the US, rates have been increasing in recent years. Of course, adolescents and young adults are disproportionately affected. When used correctly and consistently with every sex, condoms prevent sexual transmission of HIV and other STIs as well as pregnancy. That being said, because condoms are considered to be less effective at pregnancy prevention, it is always recommended that they are still used even with higher or moderately high contraceptive methods, which puts adolescents at high risk for STIs as well as pregnancy. Given the importance of condom use for this population, we sought to examine trends in adolescent condom use, taking a global perspective. To do so, we synthesized publicly available data from 3 nationally representative household or school-based adolescent surveys illustrated on this slide. So we took data from the Youth Risk Behavior Survey, the Healthy Behavior of School-Age Children Survey, and the Global School-Based Student Health Survey. From publicly available data, we were able to summarize prevalence, and if there was sufficient data, we were able to trend it to look at first year available, the year that condom use peaked, as well as the most recent data. On this slide, you'll see that we've summarized the data in a little bit more detail. Looking at the Youth Risk Behavior Survey, it was administered for 9th to 12th graders in public and private schools in the United States. And this has been done every other year since 1991. And this synthesis data was collected up and through the 2017 cycle. The Health Behavior of School-Age Children Survey is primarily conducted in Europe among 15-year-olds. We included data from 34 different countries as well as Canada in the survey years listed here. And then finally, the Global School-Based Student Health Survey is implemented among 13 to 15-year-olds in several different regions, and we included data from 30 countries in Central and South America, 17 countries from Sub-Saharan Africa, and then 14 countries in East Asia and the Western Pacific. This data was collected between 2003 and 2017. Across all 3 surveys, condom use was defined at last sexual intercourse and the indicator synthesized in this analysis. So here are the trends in condom use. We've stratified them by sex for the United States and Canada. Data taken from the Youth Risk Behavior Survey and the Health Behavior of School-Age Children. Overall, you can see that prevalence in condom use was higher in Canada than the United States. However, condom use does decline in both countries in the more recent years. This slide presents trends for males from the 34 European countries participating in the health behavior of school-age children. Again, you can see notable declines in the more prevalent years, looking at 2009 to 2010, as well as the 2013 to 2014 cycles. And then again, a similar pattern for females. Moving on to the findings from the Global School-Based Student Health Survey. This one combines males and females. So among 17 countries from Sub-Saharan Africa, prevalence of condom use is clustered somewhere between 40 and 70%. The highest noted in this cluster of data was from Mozambique, which was 72.7% in 2015. And the lowest was from Tanzania in 2014 with 31.2%. There is very limited country level data for us to be able to trend. And then looking at the 30 countries from Central and South America, prevalence of condoms was between 50 and 80%, ranging from the lowest of 47.4% in Ecuador and then 85.9% in Uruguay. Much like Sub-Saharan Africa, there's limited data to trend. Estimates are really only from 1 or 2 time points for many countries. And then 14 countries were included from East Asia and Western Pacific. Prevalence of condom usage range anywhere from 25.5% from Kiribati to 62.4% to Thailand. Again, country-specific data to trend was limited. For those regions where there was sufficient country-specific trend data, we summarized prevalence of condom use, or the mean prevalence if combining multiple countries, in this case in Europe, for the initial year of data collection, the peak year of data collection, and then the most recent if that was different from the peak year. As you can see, across the US, Canada, and Europe, condom use tended to peak in the 2000s and has declined since. In conclusion, our synthesis suggests that adolescent condom use has overall declined in recent years in North America and Europe. Unfortunately, there has not been enough consistent country-level data in Africa, South America, East Asia, or Western Pacific to be able to trend that data, although general patterns are suggestive of stable and possibly increasing condom use. There's a general lack of population-based data on condom use for the Middle East and West Asia. And as a synthesis project, there is a lot of additional work that needs to be done, including a much more in-depth examination of declines in North America and Europe, including test of trends, investigation of potential reasons for changes in condom usage. And there's additionally a need for more routine data collection at a country level. Ultimately, taking this global perspective should yield relevant country comparisons that can form interventions to increase condom use overall. Thank you so much for taking time to listen. I provided my contact info as well as Dr. Kuman's. If you have any questions or comment, please feel free to reach out. Thank you.